just walking the probe, and it goes in. I'll add what 9 millimeters here. There you go. 9. All right. Who was saying, why do you post premolar root canals? They're not challenging. They're just single rooted. Some of them are single rooted, single canal teeth. So we don't need to see those. Well, take a look here. This was apparently a simple root canal, right? Single rooted. He failed. So that's why I always say, don't get so cocky to think that you know it all. Sometimes the world kind of humbles you. I mean, I didn't do this root canal, but that could have easily been me. It looks like a pretty decent looking root canal. Again, looking decent looking doesn't mean anything. Do you see microorganisms on this x-ray? So this looks like a good looking root canal, but of course you don't see microorganisms, and that's why this root canal has failed, is because of the presence of microorganisms inside of the canal. All right, so there is no such thing as an easy root canal. Every case is a learning case, and if you think that your root canals don't fail, then you're gravely mistaken, because very likely the patient that you've done a root canal on, your root canal has failed, that patient probably ends up in another office. And so you don't see your failed root canals. So the success rate for a root canal on a vital tooth is about 90%. Even that is not 100%. So out of 100 cases that you do a root canal on a vital case, 10 could fail, and you would never see them. The classical view of a Coke bottle preparation. So that tells me that the dentist who did this root canal used Gates Glidden drills. And look at that, Coke bottle. All right, periapical lucency here and here. This patient actually had some partial paresthesia of his lower submandibular area, chin and lip, because of this. So we're gonna have to redo this root canal, of course. That's a crown on the tooth, so we're gonna need to go through the crown and take care of this mess. Please, when a patient comes to you with a toothache, do your diagnosis properly, meaning that put the tooth through your diagnostic stages and steps. So before you recommend anything, okay, so this patient claims that he went and saw his dentist about a year and a half ago with a toothache. And what he explained to me, his symptoms a year and a half ago when he saw his dentist, all pointed to the nature, the irreversible pulpitis nature of the pulp tissue. But instead of recommending a root canal a year and a half ago, this dentist recommended a crown. So this patient has had this crown for a year and a half, still with the irreversible pulpitis. So a misdiagnosis led to this patient suffering for a year and a half. So this patient has had to deal with a tooth with irreversible pulpitis, all the signs and symptoms of irreversible pulpitis, for a year and a half, when with proper diagnosis, he wouldn't have suffered for a year and a half having to deal with this tooth. So dentist puts a crown on the tooth, and patient suffers. Then the patient goes back, and the crown gets the bite gets adjusted, and all of that stuff. And all of this time, patient is suffering. And finally, the crown pops off, and the patient goes back to the dentist, and the dentist re-cements the crown and says that your tooth is cracked, so you need a root canal. Anyways, it was just all a misdiagnosis from the beginning. All right, so now we scheduled them for a root canal. This patient was referred to me for endodontic treatment of tooth number 19. Again, multiple angulation PAs is very important, so make sure you take multiple angulation PAs, be able to read your PAs, and proper diagnosis can save you and, more importantly, your patient a lot of pain and suffering. Okay, so take a look here. Look at this tooth. History taking is also important. So patient says about a year and a half ago, there was something in her food, and he bit down, and everything started from there. Tooth, she believes that she cracked the tooth. She never went to her dentist to have the tooth checked, and for the past year and a half, she's been just dealing with the fact that she can't really chew on the left side. She's been very careful chewing on the tooth. Recently, she was eating a hamburger. There was something in the meat that she bit down on. So she traumatized the tooth again, and this time the pain was pretty severe. So she went and saw her dentist, and from there she was referred to us. And that's why it's really important to be able to take a good history of the tooth, ask all kinds of questions to make sure that you've taken a good history of the tooth, and then you go to your diagnosing properly. So I found the tooth to be there was actually the occlusal part of the filling was missing from this tooth. So immediately I look at the other side, and I can see a crack on the mid-lingual wall of the tooth. The crack dissects the tooth this way, distally and apically. All right, so percussion, palpation. Percussion was tender, palpation was within normal limits, and of course, what do we do next? We probe, and I probed along the fracture. So I probed along the fracture line, and it probed 9 millimeters along the fracture line. The other thing is taking multiple angulation PAs. Sometimes you get lucky, and these cracks are substantial enough that you can actually see them on these PAs. And take a look here. Look at this. You don't see it much on this. You can kind of see it on this x-ray too, but this was the money shot, and just the right angulation that you can actually literally see the fracture there. So in this case, tooth being in this condition, I recommended extraction. All right, so proper diagnosis leads to proper treatment, or in this case, no treatment. No treatment sometimes is a lot better than treatment. Okay, so let's analyze this case. This patient was referred to me before some of you complain, why didn't I say this? This patient was referred to me for endodontic treatment of tooth number 3. Tooth, as you can see, part of an old bridge. Patient says the bridge is 25 years old. Okay, so recently tooth started to bother her, and she went and saw her dentist and was referred to us. So again, a thorough examination, evaluation, history taking will lead to hopefully a proper diagnosis. All right, so take a look at the tooth here. You can see the bridge, of course. You can see that large periapical lucency here, and a huge one here. I'll show you another angulation. Look at all of this stuff. Okay, we'll talk about that again later. But take a look here. Look at the bone loss here. There was about 2 or 3 millimeters of gingival recession on the buccal, about 9 millimeters of gingival recession on the palatal. So pretty much the entire palatal root was exposed and out of the bone. There was no bone there, and there was no gingiva. So the whole palatal root was exposed almost, all the way to the apical area of the palatal root. All right, so percussion tender, palpation tender, probings. Now let's talk about probings. All around, you probe all around. You just don't probe the buccal. Probing on the palatal side, on the mesiopalatal side, 9 millimeters of probing, okay, on the mesiopalatal side. And take a look here. You can see that large periapical lucency now associated with the palatal root as well. You can see the periapical lucency here and here too. Again, multiple angulation PAs. Look at this. Look at all of this. Look at that huge periapical lucency associated with the palatal root right there. What do you think this is? What do you think all of this is? Put in the comments. What do you think all of this is? All right. So, looking at this tooth, the overall look of the tooth with buccal and more substantially, more severely the palatal gingival resorption and osseous resorption and the deep pocket and all of this infection and everything. Is this tooth worth trying to save? No, not according to me, my opinion, no. So I recommended extraction. So tell me what all of this is in the comments. I can post these cases all day. I mean, this is the kind of quality of work that I see as an endodontist all day long. So take a look here. This patient was referred to me for endodontic retreatment of tooth number 24. So take a look here. You can see that's tooth number 24, crown on the tooth, and a large periapical lucency, previous root canal. Root canal, according to the patient, was done many years ago. She recently developed a large swelling on the labial side of the tooth that popped on its own. Plus, the dentist put her on antibiotics. Take a look at the tooth and let me show you clinically what we have with this tooth. So that's tooth number 24 right here, and look at the labial swelling, and look at the sinus tracts. There are two sinus tracts, one here, and that's the tooth. So as you can see, the tooth is erupted superiorly because of the infection. The infection has literally pushed the tooth up superiorly. You can see it's longer than tooth number 25. Again, I showed you the labial swelling and sinus tracts. Tooth had Miller class 2 plus mobility. Probings were 4 to 5 millimeters all around. And looking at the PA again, take a look at the PA. And that's the PA of the tooth. And look what happened here. This dentist perforated the tooth in the apical area, so didn't respect the apical curvature of the tooth, the anatomy of the root of the canal, and ended up instrumenting to here, couldn't make the turn, and kept picking and forcing the file. Picked with a file and just went straight right out of the canal. So perforated this root, and again you can see the periapical lucency. So looking at this tooth again, just because I'm an endodontist doesn't mean every single tooth that comes into my office, every single patient will need a root canal or the endodontic retreatment. I make a proper diagnosis, then I do a risk-benefit assessment for the patient, and then I present the case. So based on the overall look of this tooth, what happened to this tooth is not worth trying to save. Again, just because I'm an endodontist doesn't mean that every root canal needs to be redone or every tooth will need a root canal. All right, so I'm not going to be the man with a hammer that all he sees is nails. So I recommended extraction. Another case that I want to discuss with you is this patient here. Patient's dentist referred him to me to evaluate tooth number 30. According to the patient, the root canal was done a few years ago in Mexico, and patient remembers that it really hurt, and the dentist had a really hard time. He remembers the dentist talking about the curvature of the root or something like that. Anyways, now you see what the patient was talking about here with the curvature of the root, and the dentist having a hard time, and I think the dentist was complaining to the patient or her assistants or something like that about the curvature of the root that the dentist picked up in that conversation. Anyways, overheard and picked up. So you can see recurrent decay here, crown, short fills, large periapical lucency here, and smaller one right there. And you can see the curvature of the canals were not respected. So this dentist kept picking on this canal with a straight file and almost perforated, as you can see, to the outside. So these cases, reestablishing this curvature, finding this curvature with our files now has become very, very challenging, because all our files now want to follow this path that was artificially created, and this ledge that was created right there. So this now is a challenging case for us. Only if this dentist respected and appreciated her own root canal limitations, this would not have happened. Now, I'm looking at tooth number 30, and I'm like, what the heck is going on with tooth number 29? Okay. So take a look here. You can see inflammatory resorption happening here as well, and of course, a huge periapical relucency, J-shaped radiolucency here. All right. Now, intraorally, when you look, and that's the tooth here, and that's the there's a sinus tract right here. That's tooth number 29. That's tooth number 30. Surprisingly, this tooth probed 2 to 4 millimeters all around. So I asked the patient, it's a virgin tooth, by the way. So I asked the patient, I said, was there ever any trauma to this tooth? And patient thinks for a minute and says, no, I don't remember any trauma. I'm like, are you sure? Because I'm looking at your tooth, you don't even have a filling in this tooth. So have you had braces or anything like that? Patient says, no, I've never had any. I've never had orthodontic treatment and never had braces. So I'm like, man, this just seems a little odd. I checked the occlusion. The occlusion is fine. Lateral and, of course, everything else. And the occlusion is fine as well. So I said, are you sure? He says, yeah, I'm positive. But I do remember using this tooth to open beer bottles. I'm like, oh my goodness. So I went ahead and used my surgical operating microscope. You know, surprisingly, there were crease lines in the tooth, but I didn't see any cracks. So this could be endoperio, along, of course, with inflammatory resorption here. Overall, this tooth has a very guarded prognosis. So I went over all my findings and went over options with the patient. We can try to see if we can save the tooth. Very guarded prognosis, no promise or guarantees. Or he could just choose to have it extracted along with tooth number 30. And again, I don't force my patients to make a decision while they're sitting in the dental chair. I present the case, their issue or issues that they're at my office for, go over findings, go over options, and then let them choose, give them some time.